Now the third thing is hypercoagulability. Hypercoagulability is any blood disorder or any coagulation pathway alteration that will lead to the thrombus formation. Hypercoagulability is due to two factors, two reasons basically. One can be primary and the other one can be secondary. Primary are genetic factors and secondary are acquired factors that will lead to the hypercoagulable state that will promote thrombus formation. Here we will first study what are the primary or genetic factors that promote thrombus formation by making our body's hypercoagulable state. First one is factor 5 mutation. We know factor 5 is involved in clotting pathway. Factor 5 is important in intrinsic pathway as well as extrinsic pathway. So factor 5 mutation will lead to the hypercoagulability. How? This factor 5 mutation will render factor 5 resistant to cleaved by protein C. We know our endothelium has thrombomodulin. Thrombomodulin was binding thrombin and thrombin was converting protein C into its activated form, and that protein C was inhibiting our two factors, inactivating our two factors. One was the 5 and the other one was the 8. So in this factor 5 mutation, factor 5 alters its form in such a way that it becomes resistant to be cleaved by that protein C. So this is how factor 5 mutation will lead to the hypercoagulability. Second thing is prothrombin mutation. Prothrombin mutation will lead to the increased in expression of this prothrombin. So whenever there is large amount of prothrombin, it will activate into a large amount of thrombin, and that will lead to the thrombus formation. And the third thing is factor 7, 9, 11 and fibrinogen more expression. It is a genetic problem in which these clotting factors are expressed in large amounts. These three are the commonest reason, most common reason for this hypercoagulability. Now let's move towards less common factors. Less common factors include antithrombin 3 deficiency, which is again a genetic problem, protein C or S deficiency, antithrombin 3 deficiency. What was the function of antithrombin? Antithrombin was binding with our heparin sulfate that is present on our endothelium, and when it will bind with the heparin sulfate, it was inactivating, it was cleaving our three clotting factors, that was the factor 9, 2, 9 and 10. So this is how antithrombin 3 deficiency will lead to the hypercoagulability. Now protein C or S deficiency, again as I have told in factor 5 mutation, that whenever there is protein C or S deficiency, there will be no cleavage of two clotting factors, that is factor 5 and 8. So this is how this will lead to the hypercoagulability. Now another thing comes, that is homocystinemia. How homocystinemia will lead to the hypercoagulable state? Homocystinemia basically is an inherited deficiency of cystathione beta synthase. In this there is no cystathione beta synthase enzyme, or less cystathione beta synthase enzyme. If this enzyme is not in appreciable amount, this will lead to the prothrombic endothelium. Now the fibrinolytic effects, name depicts as there will be some problem in fibrinolysis. So these were the most common, these are the less common, and this is rare reason for hypercoagulability. Now let's move towards the secondary reason. Secondary reason are acquired, like they are not genetic, we acquire them through during our life. First one is immobilization. As I have explained previously, immobilization will lead to the stasis of blood, and when there is stasis of blood flow will no more be laminar, and that will lead to the endothelial activation, and there will be the contact of platelets with our endothelium. That is how immobilization will lead to the thrombus formation. Myocardial infarction. In myocardial infarction, basically there is compromised blood supply to some portion of the heart that will be necrosed, and that part will no more be contracting. So whenever there is no contraction in some portion of heart, there will be the stasis of blood. Again, there will be the reason stasis, and that will lead to the thrombus formation. Atrial fibrillation. We know mitral valve stenosis, rheumatic mitral valve stenosis, in which our mitral valves is stenosed, and there is atrial dilation, and when there is atrial dilation, there will be atrial fibrillation, and there will be the stasis of blood. Again, there will be the thrombus formation. Now there comes another reason. It is surgery. In surgery, we know we are injuring our endothelium. So if endothelial injury is severe, then there again can be thrombus formation. So in surgery, the basically reason is endothelial injury. Or there can be another reason. After surgery, we usually advise our patients to get some bed rest, and bed rest will there will be immobilization of our bedridden patient, and there will be the stasis of blood flow, and that will lead to the thrombus formation. So surgery promotes thrombus formation in two ways. Like it forms thrombus through endothelial injury as well as through the stasis of blood. Now another thing comes, that is heparin induced thrombocytopenia. How this happens? If we're giving unfractionated heparin to our patient, to somebody, this unfractionated heparin, let me explain here. Unfractionated heparin will induce some antibodies, and those antibodies will bind with platelet factor 4 and as well as heparin, and when they bind with platelet factor 4, they will lead to the activation of platelets, and activation of platelets will lead to thrombus formation. There will be platelet activation, then aggregation, and more platelets are used when we are giving unfractionated heparin. So there can be thrombocytopenia, like there can be less number of platelets in our circulation because there is using up of these platelets. The antibodies are binding to these platelets factors, and the platelets are using up in the process of thrombus formation. Now there is antiphospholipid antibody syndrome. What is this syndrome? A syndrome in which our immune system mistakenly forms some antibodies that causes tissue damage. This can be this is a syndrome in which our own body is making some antibodies which are making our endothelium injured, and that injured endothelium is a reason for hypercoagulability and are the reason for the thrombus formation. So here is some immune system will cause endothelial injury, and we know the consequence of endothelial injury. Now another thing comes, that is cancer. Cancer basically itself can release procoagulants factor are released from the tumors that will help in thrombus formation. Now comes the contraceptives. Whenever we are taking some oral contraceptives, there is increased hepatic synthesis of clotting factors and reduced hepatic synthesis of anticoagulant factors. So in oral contraceptive, there is increased hepatic synthesis of clotting factors and reduced clotting factors inhibitor formation. This is how oral contraceptives favored thrombus formation. Now comes the age. With the advancing age, our endothelium is no more expressing prostaglandin I2. We know our normal endothelium was expressing nitric oxide and prostaglandin I2 that will help make our platelets inactivate. So whenever there is no activation, there is no clot formation. But with the advancing age, there is less formation of this, less release of prostaglandins from the endothelium, and that will lead to the thrombus formation. These were the three reasons for the thrombus formation. First one was endothelial injury, second one was blood flow, abnormal blood flow, and third reason is hypercoagulability. To study the fate of thrombus, in the previous video I have explained what is how thrombus is formed and what are the factors involved in thrombus formation, and we have understood those factors in details one by one. Now a thrombus has formed inside our vessel. Then what is the fate of the thrombus that has formed inside our vessel? First fate can be of propagation, like it will be go on accumulating more and more platelets, more and more fibrin, and it will be increased in size and it will occlude our vessel. So first thing is propagation. Second, embolization. It will dislodge from its original site and will start moving in our circulation and will causes infarction in some other portion if it is occluding any blood supply to a portion there. First thing is propagation. Second fate can be immobilization, dislodgement from the original site. Third thing is dissolution. In this, our blood clot is dissolved. How blood clot is dissolved? There is fibrinolysis. How fibrinolysis occur? Our endothelium has tissue plasminogen activator. Tissue plasminogen activator will convert the plasminogen present in our bloodstream into its activated form, that is plasmin, and plasmin is fibrinolytic protein. Plasmin will causes the fibrinolysis and there will be the dissolution of clot or thrombus. Fourth thing is recanalization and organization. Now in this there is ingrowth of endothelial cells, smooth muscle cells, and fibroblasts. Let's see. This is a vessel. Here is a clot. Here is a thrombus present. First of all, there will be the recanalization. Recanalization means there will be again formation of some canals in the clot that will resume the original lumen of the vessel. How this this recanalization occur? Basically, the entrapped leukocytes and platelets here releases some enzymes in the center that will lead to the recanalization. And after recanalization, suppose there is recanalization, and now there is organization of this clot, this thrombus into the vessel wall, and only presence of a small mass of connective tissue will depict the original thrombus. So these were the four fates of the thrombus. Thank you for watching.